Welcome to Ageless and Outrageous, your favorite podcast about how to age amazingly. I'm urogynecologist and hormone and sexual health expert, Dr. Kristen Jackson. Every week, my incredible and knowledgeable nurse practitioner, Rosalind Arp, and I share our combined 30 years experience to guide both men and women as they age. Listen as we dive into a variety of topics, including hormone optimization, pelvic floor health, maintaining a vibrant sex life, weight gain issues, and skin, hair, and body changes as we age. These real-life insights are always rooted in solid scientific knowledge. Tune in for a dose of laughter, knowledge, and an honest perspective on the incredible adventure of growing older.
Welcome to the podcast, where today we are talking about male sexual health. We are always talking about men becoming better educated about female sexual health issues, but today's episode is about the opposite. What are the top 5 things women need to know about their male partner's sexual health? And the first big topic to discuss is erectile dysfunction. This is when men either have difficulty achieving an erection when they want or maintaining the erection as long as needed.
Erectile dysfunction is extremely common as men age. There's actually a statistic that starting at age 50, the rate of ED is the same as the decade that you're in, meaning that 50% of 50-year-old men suffer from ED, and 60% of 60-year-old men, and 70% of 70-year-old men, and so on. We do know that the rate of ED continues to increase as men age. But let's look at how an erection happens in the first place. When men are sexually stimulated, it starts in the frontal lobe of the brain. Parasympathetic signals are sent down the spinal cord, and they leave through spinal nerves to stimulate the penis. There are several cavities in the penis that then fill with blood. When they fill firmly enough, they press on the veins that would normally carry the blood away, and all that pressure on the veins blocks them so the blood stays within the penis, keeping it hard. Testosterone also plays an important role, not only in a man's libido, but in the sensitivity of his penis to stimulation.
So that means if a man's having trouble with an erection, it might be from a vascular cause, like a blood flow issue, a neurogenic or nerve-related cause with either nerves in the spinal cord or the peripheral nerves out to the penis, or a hormonal cause such as decreased testosterone levels.
Strong blood flow is the first requirement for a good erection. That means having big open arteries that can bring blood into the penis. If you have high blood pressure, atherosclerosis, or diabetes, these can all impede the blood flow. So can radiation to the pelvic area, trauma to the penis that might hurt the blood vessels, or Peyronie's disease, where there might be scar tissue around the blood vessels. In fact, ED has been called the body's early warning system for cardiovascular disease. If you imagine the vessels in our body are like the pipes in our house, think about which pipes are likely to clog first. Is it going to be the great big pipes or the little tiny pipes? It's probably going to be the little tiny pipes. They're more likely to get clogged up with hair or whatever else goes down our drain. The arteries to the penis are like the small pipes in our house. They're just about 1 millimeter in diameter. If you compare that to the arteries around our heart, they're 3 times as big. They're 3 millimeters. Before a man experiences classic signs of heart disease, like pain in his chest, a heart attack, or a stroke, he might have experienced ED. It's the big pipes around his heart that are showing signs of clogs. So we know by default that the small pipes are already blocked up. And in fact, if young men struggle with ED, there's up to an 80% chance of later cardiovascular disease. So ED is not just a sexual health issue, it's really a cardiovascular health issue.
And just to clarify, when you're talking about tiny pipes, you're talking about the arteries that feeds into the penis, right?
Yes, all men have tiny pipes in the penis. That doesn't mean they are tiny.
Yes. Okay. I was just thinking about that, and it might be taken the wrong way
by some of our male listeners. That's right.
Yeah. But yes, the second requirement for a great erection is related to the nerves and their sensitivity. Just as when women age, the nerves to their clitoris becomes less sensitive and require more stimulation to respond. The same thing happens with men. As they age, the stimulation that once felt great and could easily stimulate an erection doesn't seem to work as well. Plus, if they have developed any nerve conditions like Parkinson's or MS, this can decrease nerve sensitivity. So can having a stroke or any injury to nerves in the back or pelvis. Finally, poorly controlled diabetes leads to nerve damage, and that includes nerves to the penis.
And the nerves for sexual stimulation are part of our parasympathetic system. You may know our sympathetic system as the fight or flight response. Well, the parasympathetic system is the opposite. It's the rest and digest response. We need to have good parasympathetic tone in order to have a successful sexual experience. That's why things like anxiety and stress really have a negative effect on erections, since they raise our cortisol level and activate our sympathetic nervous system. It's really hard for our body to rest and think about sex when we're in a fight or flight situation. This is also why we see more erectile dysfunction in men who have sleep apnea. The deepest part of sleep is REM sleep, and that's when our parasympathetic tone is the most active. That's also the time during sleep when men get nighttime erections. Men who have sleep apnea spend a lot less time in REM, which leads to fewer nighttime erections and actually an increased risk for ED overall. And I actually think it's interesting that in early studies, in order to measure nighttime erections, they would sometimes put a roll of stamps around the flaccid penis. And if the roll of stamps was broken when the man woke up, they knew he had an erection through the night. Now it's a little bit more sophisticated, using a device that has two rings. One goes around the base of the penis and one goes around the tip. And they can actually measure how much blood the penis fills with overnight.
That's really interesting. I'm going to look at stamps differently.
A roll of stamps differently.
Yes, but the final ingredient needed for a great erection is testosterone. Testosterone optimizes and helps increase the nerve sensitivity in the penis. There's a lot of testosterone receptors in the penis, which means having good testosterone levels help increase blood flow to the penis, as well as increasing their libido or desire to have sex. We know testosterone deficiency leads to decreased libido and decreased nighttime erections, but it's also associated with irritability, depression, decreased muscle mass and bone mass, increased fat around the middle, and insulin resistance. So replacing testosterone not only has amazing positive results for ED, but also significant overall health benefits.
Right. And those health benefits are actually seen in both men and women. But for men to have the best erection, they need good blood flow, high parasympathetic nerve tone, and optimal levels of testosterone. We know that upon awakening, men should be in a good parasympathetic nerve state. And we also know their testosterone levels tend to be highest first thing in the morning. But society tells us that the best time to have sex is late at night. You know, you have your date night, and then you go home and you wrap it up with an evening of sex. But many times, if you're lucky enough to have date night, by the time you get home, you're full, maybe you feel a little bloated, you've had a glass of wine, and you're tired. So nobody's really excited about sex. So this is the first thing we want women to know about men's sexual health. Set an alarm for better sex. Start thinking about having sex in the morning when your man's parasympathetic tone is high and the testosterone is at its highest. Take advantage of that.
Yes, we should be using that to our advantage for sure. I actually mentioned it to a patient yesterday, and she was like, that's very interesting because yes, at nighttime, I go to bed at 11:30. I'm just really so tired. Even though my libido's high, I'm not really that in the mood, and he's not either. So I mentioned that. She's like, oh, I'm going to have more morning sex then, if that's the case.
Exactly. A good option for retired couples who don't have to rush off to work in the morning.
Yes, for sure. When we evaluate men for ED, we want to first make sure they're not taking any of the many meds that interfere with erection too. This can include antihypertensive drugs like diuretics and beta blockers, antidepressants like SSRIs, anti-anxiety medications, and antipsychotics, and also some antihistamines like pseudoephedrine, narcotics, and anti-androgen drugs can cause erectile dysfunction. So if men are noticing decreased erections, they should look into also their drug list to see if there's anything that they can change to help with their erections.
Right. And unfortunately, that drug list, as you mentioned, is pretty darn long.
Yes. But let's talk about the types of treatment we can recommend.
So this is where we have a large number of drugs to choose from, and we owe that to the drug company Pfizer. Before 1992, the original term for ED was impotence. But in 1992, the National Institute of Health decided to change the name to erectile dysfunction to remove some of the stigma that men felt when they were seeking treatment. That didn't really make a big difference until 1998, when Pfizer launched its first ED drug, Viagra, or sildenafil. Pfizer also marketed the heck out of the terms ED and their drug Viagra and made it very mainstream for men to talk about ED and seek treatment for it. The drugs to treat ED are called PDE5 inhibitors. And as I said, you may know about sildenafil, which is Viagra, or tadalafil, which is Cialis. They were initially testing these drugs as a treatment for high blood pressure. They work by increasing intracellular cGMP, which acts like nitrous oxide, and nitrous oxide causes vasodilation or relaxation of the blood vessels. If we can relax the blood vessels in the whole body, we can lower blood pressure, and that was their initial hypothesis on how these drugs would work. But it turned out, though, the drugs didn't do a great job at consistently reducing blood pressure. But the study participants reported better erections while they were in the drug trials. So Pfizer realized they didn't have a great blood pressure medicine. They had the first drug that could treat erectile dysfunction.
And this is the second thing we want women to know about men's sexual health. Don't call it an erection pill or sex pill. We should call it a muscle relaxation pill. It sounds much better than the little blue pill.
That's right. No man wants to think that they need a sex pill.
Yes. And once Pfizer made men feel better and have stronger and longer erections, they suddenly realized that their wives could no longer keep up. So these are men who previously maybe shied away from sexual intercourse because their erection wasn't as good as it once was. But now we've improved that, and their wives are saying, oh my gosh, what do I need to do to keep up with them? Which is actually what we love to do, which is female sexual medicine, which helps women enjoy sex with their partners as well.
In addition to medications, there are several other options for treating erectile dysfunction. There is a vacuum device that can pull blood into the penis when needed. This device can be used alone or in conjunction with the PDE5 inhibitors we discussed. Sometimes they'll add a ring at the base of the penis once it has filled with blood to help keep the blood there and maintain the erection. There are also penile injections. There's only one FDA-approved one, and it's called alprostadil, which is a prostaglandin, but many urologists also compound injectable medications, including things like atropine, hydrochloride, or other vasoactive drugs. These injections can be given up to 3 times a week, but many men don't like them because of the need to have a penile injection, and they do have a risk of priapism, which is a long and painful erection that doesn't go away. I believe alprostadil also comes as a penile insert, so that takes away the need for an injection and also has less of a risk of priapism as compared to the shots.
Also, some people may be aware that there are some prostheses that can be inserted into the penis to help with erection. These are 2 cylinders that go into the shaft of the penis and a pump that is usually in the scrotum. The pump moves fluid into the cylinders when an erection is desired and then release the fluid when you're finished. It's actually interesting to me to see this because my first physiology class, or anatomy class, one of our cadavers actually had a penis pump. So that was quite interesting to see.
That's great to find. I remember the first one I saw was when I was a medical student doing a urology rotation. The man we were going to see had a prosthetic pump. I thought he was going to be so embarrassed about it. But when I walked in the room as a 25-year-old medical student, he was like, want to see my pump? Dropped his pants, pumped himself up. He was so proud of it.
That sounds about right.
Exactly. So we've spent a lot of time discussing ED, but now let's switch gears and talk about premature ejaculation. This does have a medical definition, which is achieving orgasm within 1 minute of stimulation, and it's bothersome to the patient. What I think is interesting here is that the studies that tell us how long it takes for both men and women to reach orgasm. For men, it takes them an average of 5.5 minutes of penetration to reach orgasm. For women, it takes an average of 14 minutes of clitoral stimulation to reach orgasm. And there's about 17% of patients who can't reach orgasm at all. So if you look at those numbers, if men and women start to have intercourse at the same time, every man is going to experience premature ejaculation in the eyes of a female partner because he's going to reach orgasm in 5.5 minutes and she needs at least 14. But of course, the active intercourse is over by then.
Yeah, that's a big disparity.
Right. And I think if we just know that that's how our bodies work, we can easily get around that. So if a woman feels like, oh, my male partner always ends up having an orgasm before me, it may just be their anatomy. So how we get around that is we need to actually hold the male partner off for a few more minutes. So there are some numbing sprays that men can put on the penis that decrease sensitivity and allow them to last longer before they reach orgasm. We can use things like a low-dose antidepressant, which again, slightly decreases the sensitivity of the penis. Or my favorite way, which is plan to give your female partner an orgasm at first, any way she sees fit. That way you can take as long as you need and you can make it fun. And then once she's had her orgasm, or 2 or 3, you can now resume vaginal intercourse or any other kind of stimulation. So now, even if the man only takes his average of 5.5 minutes, it doesn't matter anymore because both partners are satisfied.
Yes. And if a woman is able to have an orgasm with penetration, then that really makes sense. She can have an orgasm with direct clitoral stimulation first, then you can move into penetration, and both of them can have an orgasm that way as well, which is easier for the woman to achieve after having clitoral orgasm.
Exactly. I love it. So it never made sense to me that most people think of sex as ending with one female orgasm and one male orgasm. Since most women should have the ability for multiple orgasms, then sex should really be ending with 2 to 3 female orgasms for every one male orgasm. So I think it's really empowering to educate patients that this is the way male and female bodies work, and this is how we can use them to get the maximum pleasure.
They actually did a study to see which women were able to have orgasms during penetration. And what they found is majority of these women have a clitoris that is less than 2 centimeters away from the urethra, which makes sense because during penetration, if the clitoris is close to the urethra, then it's probably getting good stimulation, unlike women who have it located further away. So this is a third thing that women need to know. Most women cannot have orgasm with penetration alone. They need to add direct clitoral stimulation. So if you're someone who can orgasm with penetration, count yourself lucky with your anatomy.
We talk to women about that all the time. The fourth thing that women should know about men's sexual health is something about prostate cancer. Now, prostate cancer in and of itself isn't related to sexual dysfunction, but treatment of prostate cancer may be. The prostate is a gland that surrounds the male urethra, and it helps provide some liquid to the semen and some nutrients for the sperm as they're coming out. Prostate cancer tends to start small and in the center of the gland. So you can have a small, slow-growing prostate cancer, and the man has no sexual dysfunction. That's because the blood vessels and nerves that serve the penis run along the sides of the prostate. A cancer growing in the center of the prostate is unlikely to affect the nerves or the blood vessels on the side. However, if the man needs treatment for his prostate cancer, that might include surgery to remove the prostate or radiation or chemotherapy. Surgery, removing the prostate, in theory, could damage the blood vessels and nerves to the penis. And there are a certain percentage of men who do have erectile dysfunction after prostatectomy. Chemotherapy and radiation don't directly remove the prostate, but they can both desensitize the nerves to the penis and may decrease the blood flow just by injuring the blood vessels to the penis. So we can see some difficulty with erection after treatment for prostate cancer.
Yeah, and many of the same treatments we have been discussing can be used after treatment for prostate cancer as well. So that's like the vacuum pumps, the injection, and the prosthesis. But the medications may not be as effective if nerves and blood vessels have been damaged by prostate surgery. So once you finish your treatment with your oncologist, it's the urologist that will be the one to take over and help you with your sexual health after treatment.
Because it doesn't make sense if your cancer doctor saves your life by removing your cancer and treating your prostate cancer, but then we don't improve your quality of life issues afterwards. So just because you have prostate cancer doesn't mean the end of your sexual life. And there are a lot of options out there that you can do to improve it. So this is the number 5 thing that women need to know. And that is that both men and women really need to advocate for their sexual health. I can't tell you how many times I speak with my female patients and say, "Are you sexually active?" And her response is, "Oh no, my husband had prostate surgery some years ago. We haven't had sex since then." And that may not have been the choice of either partner. It was just that his erection wasn't as strong and they didn't feel like they had anybody to talk about it. So sex just kind of fell by the wayside. But for most men, prostate cancer is not a death sentence. It's a very curable disease. And many men have a long number of years left after their prostate cancer is treated where they want to have a satisfying sexual life.
Yes, and this is where I feel like as women, we can really encourage our partners because a lot of my patients' husbands will not ask their urologist about treatments for sexual health after prostate cancer. Or their physicians are not asking about sexual activity and educating their patients about the many options that are available. So as their partners, we can also tell them it's okay. Like, let's just talk about it and talk to the doctor about it. This is really important to us, and this is important in a relationship, and we need to get informed about keeping our sex life alive.
Exactly. Sometimes it is the woman who has to be the voice of that. Even though now we have ED as a socially acceptable term, we still have a lot of male patients who just don't want to bring it up. But either patient can be an advocate. So if it has to be the female patient, so be it. We can take that on.
Thanks so much for listening to today's episode. No information from this recording is intended as a diagnosis or treatment for any disease. If you are enjoying the show, please subscribe so you don't miss any of our exciting episodes. And we love to hear from our listeners and would be grateful for your positive review. We'll talk next time.